Hey, it's Dr. Reiner. We're here on a new live show on Monday night. Glad you could tune in. I was kind of liking the little bit of the promo where that's our new logo that's up there. And so I was very proud that they put that up there along with the correct address. Right, that was good. The only name that's not on there is Melanie Lentz, and she's still with us. She does coming in periodically, doing some traveling back and forth. So, and then we hopefully will be adding another nurse practitioner after the first of the year, and then maybe one after that. So. We're hoping that we certainly increase the level of practitioners in our office. I can only see so many people, and even that, kind of gets cumbersome after a while. But we are, one of the things that we are doing that's kind of nice for our senior dementia patients and our Optum patients, if we created a couple of care coordinators, which are very instrumental in helping to help those people navigate the system. One of the difference between, we live in a retirement community, and there's either Medicare fee-for-service, and then there's also Medicare, which is under an Advantage plan, and there are two big Advantage plans in town, one being senior dimensions and the other being Humana or Healthcare Partners. And so one of the things that has always bothered me is how hard it is to navigate those particular systems of referrals and all of the special places you have to go for testing and all the drugs that, fit in the formulary, those that do, those that don't. And those things are very difficult to keep up with. And we as practitioners will write a prescription, and that prescription will either be denied, then we have to do a prior auth, and the patients are in the meantime are waiting for their script, and the pharmacies, I get this all the time, well, the pharmacies called your office, but your office never gets back to them. And then it looks like we're left holding the bag. And so many things today are done by electronic systems that we lose a lot in that personal connection that I had when I first started in medicine, which was quite a few years ago. Things were a lot easier. You wrote one prescription, it got filled, you wanted to get a test, you went to one place, the insurance companies paid for it. Now they're all jockeying for, if I can get the best deal at Las Vegas Radiology or Desert Radiology or Steinberg, that's where I need to go. That could change next week as they get a better deal. Patients get stuck with bills. You spend an inordinate amount of time researching patients' insurance to make sure that they go to the right facility, and then patients will try and get in to get everything done before their insurance gets canceled. You order some tests, and somebody gets stuck with the bill. So that's the insurance market, and I think it would be a lot easier and a lot better if there was no health insurance, but that's impossible. If we were on a fee-for-service basis, we wouldn't be covering the tab for the non-insured. Although Medicaid has helped a lot with that respect, but one of the issues I do see with Medicaid is patients are still going to the most expensive point of service, which is the emergency room. And it was created to try and get people health care, but not get people health care at $1,000 an office visit, which is what they would charge if you went to the emergency room. That's their fee-for-service, seeing an ER doctor, and that's outrageous for something that simply could be taken care at the office. On the other side of the Medicaid dilemma, you have a lot of people that have no skin in the game. We get a lot of no-shows for Medicaid patients. And it makes it hard to run a business when you have 3 or 4 no-shows on your schedule, and that's why I think Healthcare Partners and I think Humana decided not to take any more Medicaid. That's why Southwest Medical won't take Medicaid, because there's only so many slots in a visit in a day that you can put patients in. And when you get 3 no-shows, then you absolutely get patients that, I mean, it loses revenue, right? I mean, you had 3 people that you could have put in that spot that wanted to see you, but you had 3 books patients that didn't show. So that's a net sum gain of 3 losses, or actually 6 losses, because you could have had that revenue, and now you don't have that revenue. So, you know, the day may come when, you know, there's, like in Vegas, you have Amerigroup and you have other Medicaid HMOs, and those Medicaid HMOs kind of work because patients, if they don't show up, they still get paid. The doctor still gets paid based on a capitated rate. You're responsible for taking care of those patients, and if they don't show, well, okay, but if they do show, then you obviously have that issue where you're maybe overbooked. So getting patients in, getting them seen in a quick and efficient manner is always a difficult issue. We start out the day, you know, it takes a while for a new patient to show up. They have to fill out paperwork. Their chart has to be created. It isn't like the old day where you could slip a piece of paper on a chart, and then you could, you know, you put a folder together, you put it together, their name, their address, you got a couple of information, you write in there, and you're done. In an electronic medical record, everything has to be hand entered. It takes 3 times as long to put a chart together. Everything has to be updated. So there's a lot of work in creating patients' charts and getting people back in. Now, with all the different testing places, you go to this place or this place, and patients don't remember exactly where they went. I think it was somewhere on Rancho, but I don't remember. And now you got to turn around and figure that out, and you got to collect that data so that you can review it with the patient. And then if they're testing, if one letter is misspelled in their name for some reason, and you go to the lab, then their lab comes back and it sits in what I call cyber hell, because it's not in the patient's chart. It's somewhere, it's in your practice, and you got to track it down. And then patients will tell you that, you know, nothing else happened, but then they got discharged from the hospital or they had something else. So these are the common problems that we, as you know, patients aren't aware of those issues. But going back to the original opening statement about the care coordinators that we've done, you know, our biggest issue is referrals, prior authorizations, getting patients in there. And so we created a whole group of people that our sole task is to make sure that those things get done. Patients can get in, can get appointments. It's kind of a personal concierge service for what I call a very difficult route to go. So we're going to be coming up on a break in a few minutes, and after the break, I'm going to be re-demonstrating the part that I talked about at the close of last week's show, which was some of the colonic testing for colon cancer. I've always believed that colon cancer is a disease that doesn't have to be. It certainly could be caught, and in today's world, it's unlikely. I mean, it should be that no one really dies from colon cancer, except it's an unfortunate occurrence at a young age. But I felt like I didn't really explain it as well as I possibly could, and I want to do a comparison with the old test and show you how things have advanced and why, again, you would want to ask your healthcare provider about this particular test. And again, you want to make sure that you get that test done if you could. It's very important that you screen yourself for colon cancer. If you've had a colonoscopy and it's negative, you do not need to have another one for approximately 9 years. If you had a colonoscopy and it was positive, then usually they request you back in 3 years. Sometimes they'll do 5, but you get serial screenings in 3 years, and if that one is negative and 5 years is negative, then you go back to the routine 10-year screening. Some people form polyps very fast, and some people, there's only one exception, which I mentioned earlier, which is ulcerative colitis. Ulcerative colitis is the only disease of the colon that can cause colon cancer from an inflammatory area, not from a polyp. When a polyp grows and it allows to exist long enough, it will and should turn into cancer. And that's what we're trying to avoid, which is you can sneer that polyp early on in its infancy and prevent cancer from developing. And that's not true for all other illnesses. It's the only illness that I know that can be prevented with a simple test. And I want to talk a little bit more of that after the break. So we're going to be going into that. And then probably towards the end of the show, I'll talk a little bit about allergies, which we all are suffering from, a little heads-up information on what you might be looking to do to help avert some of the allergies. And I keep saying, well, it'll get hot enough here to kill everything, and I got to be careful what I pray for, because we'll have another 113 degrees, 20-degree summer, and I'll be cursing that thought too. So as the town grows and people start planting more grass, they start planting more trees, there really isn't anything indigenous to this area except for sagebrush and Joshua trees and a few cacti. It's only us that when we come into town, we plant grass, all types of grass, cottonwood trees, things of that nature that in the springtime stir up the allergy seasons. And then you got the high winds that blow, and they bring in a lot of pollen and a lot of other things. And so those things can be produce a lot of allergies. And if you notice in your house, you get a fair amount of dust that comes in from the wind. In fact, it's howling out there as we speak, and that can be blowing dust and other things into your home, which can cause issues. So we'll be talking about that. And of course, the phone lines should be open, and we can always digress to those calls when they come in. So we're going to go to break, and we'll come back. We'll talk about colonoscopies.